Good morning, everybody. Thank you for the great opportunity to have me today to present our project. My name is Dr. Carlos Mikel. I'm a former cardiology resident at Ain Shams University Hospitals, and right now I'm a postdoc cardiology researcher at UCLA here in California. Special thanks to the great team, my incredible team, and Professor Dr. Mervet Abulmaati for her continuous guidance and support. Today, I'm going to present our abstract comparative analysis of inherited cardiomyopathies at a tertiary high-volume Egyptian center versus IMH-OTEP African registry. So, starting with a background, inherited cardiomyopathy are major cause of heart failures, arrhythmias, and sudden cardiac death. What we try to do is we try to collect as much data as we can from Egypt, from our tertiary high-volume Egyptian center, and compare these data to the African registry. And we compare everything. We compare demographics, we compare comorbidities, we compare diagnostics, and so on. I believe we by collecting data throughout a long period of time, and by collecting data from different centers, we have a large database, and at the end of the day, we can make our own guidelines. We can have like our Egyptian or like our African guidelines for our um, pool of patients. So for the IMH-OTEP registry, they started the pilot phase, and it included South Africa and Mozambique. And the next phase will be including the blue countries, as you see on the map here. Um, so let's start giving a quick word about the African registry. It's a Pan-African multi-center hospital-based cohort study. It has two aims. The primary aim is describing the clinical characteristics, genetic causes, prevalence and management, and outcomes of cardiomyopathy and myocarditis in children and adults. This is the primary aim. The secondary aim is, of course, identifying our barriers, what like prevent us from implementing more healthcare, more like guidelines. So we wanna like reduce the morbidity and mortality of cardiomyopathy. So patients will be evaluated on three stages: stage one and two and three. Stage one is a non-invasive, so we have to confirm the diagnosis of cardiomyopathy and like the functional type, the etiology, and exclude, of course, other diagnostics. Stage two, it's invasive one. It has to be in some institutions that are like equipped with um, with um, with the exact diagnostic modalities that we need. Stage three is a genetic one, and it is very limited right now, but I guess it's very promising if we have enough like financial support, and if we have enough evidence of how accurate it is. So our experience in the Heartbeat Center, the tertiary high volume Egyptian center, we started collecting data from January 2015 to March 2023. And of course, like data like age, sex are de-identified for the patient. And we focus on comparing the age of presentation, the family histories, the comorbidities, and type of arrhythmias, and the type of cardiomyopathies, of course. Data is like giving us a prelim view about what's going on, and we will keep collecting data, and we will keep presenting it until we have like more patients, more solid guidelines that we can move forward from. So for results, as you see here, we have like different types of cardiomyopathy, starting from hypertrophic, dilated, restricted cardiomyopathy, and right ventricular arrhythmogenic cardiomyopathy. We also have the non-dilated left ventricular cardiomyopathy. The most prevalent types are the hypertrophic and the dilated, with the dilated being the most prevalent one. And from literature, we know that cardiomyopathies account for like 20 to 30% of cases of heart failure in adults in Africa. So, which gives like this topic like a great importance to study and like a great way to have guidelines for. Um, Collectively, like as I told you before, most common type of cardiomyopathy is a dilated one in both like the Egyptian tertiary high volume center and the African registry. As you see here in our bar chart, the dilated cardiomyopathy in Egyptian center was like 67.7%, and in the African registry it was like 72%. We studied family history of cardiomyopathy across our patients, and also we studied family history of sudden cardiac death. And as you see per our like data, the family history of dilated cardiomyopathy is the most prevalent one, and family history of sudden cardiac death in patients who have hypertrophic cardiomyopathy is the most prevalent one. Um, Collectively, family history was positive in 31.4% for the African registry, while it was 14.5% for the our tertiary heart high volume Egyptian center. When talking about the median age of presentation, we found like some discrepancies in the Egyptian center. We have like the median age at presentation is 48, and in African registry it's around 35. And what I want to say here is like this depends on a lot of um, health care illiteracy among people, and this depends on having modalities for diagnosis and like centers that can provide these diagnostics for patients suspected of cardiomyopathy. Collectively, again, family history of cardiomyopathy, it's of course for the collective cardiomyopathy, not a specific type. It was 14.5 in the Egyptian center, and it was 31.4 in the African registry. For the median age, it was for Egyptian center, it was 48, and for African registry, it were around 35. We also studied comorbidities that accompany like the cardiomyopathy, and we found that hypertension and diabetes are the most common or are the most found comorbidities across our patients. For the arrhythmias like accompanies cardiomyopathy or like that happen in the cardiomyopathy patients, there is a lot of like types of arrhythmias that we found or that we studied across our patients and across the African registry. And like I want to highlight that the ventricular tachycardias in the dilated cardiomyopathy were the most common, and followed by the AF or atrial fibrillation, which was like 30 patients. Collectively, again, the comorbidities, we can see that hypertension and diabetes are the most common in our center. And for the African registry, we can say it's HIV, hypertension, and other comorbidities. For the arrhythmia prevalence in cardiomyopathy patients, that the arrhythmias that happen in these patients, it's ventricular and atrial. We compare both together, and we found that in the Egyptian center, the atrial arrhythmias are more common than the African registry, while in the African registry, we have more ventricular arrhythmias than in the Egyptian heartbeat center. We studied also like uh, the ways of diagnosis of cardiomyopathy. We have CMR, we have Holter, we have genetic tests, and as you know that CMR is like um, a very expensive diagnostic modality, and it needs specific centers. So across all Egypt, it's just a few centers or like a small number of centers that can do CMR. And we find that it's it was performed in only just 31 0.6% of cases in the African registry, and in our registry, it was like 12.5%. Let me summarize the diagnostic modalities again. For the tertiary high volume Egyptian center and the African registry, both used MRI. It was like around 31.6% for the African registry patients, and it was around 12.5% for the Egyptian center patients. In both registries, testing was limited, and we really need to study that. Like genetic testing is expensive modality, and we really need to know if it adds more than the CMR or not. So we have to study that. I want to also highlight the ICD use. We have 31% of patients in our Egyptian centers that got ICD insertion due to the arrhythmias that they got due to cardiomyopathy. And for the African registry, it was just 11.3% of the patients who got like arrhythmias due to cardiomyopathy. In conclusion, I want to say that we have a very good amount of data. We have a lot of patients with cardiomyopathy. We need to study more. We need to collect more data. So we have like more comparisons, and we have like collaborations between the Egyptian and the African centers. And then we have our own guidelines, so we can go from there to study more about like genetics, to study more about more diagnostic modalities, to have our own guidelines for our African pool of patients and Egyptian pool of patients. And that will help us a lot in diagnosis, in management, in like setting our own guidelines, and study more about that. Thank you again for having me today. I would really be happy if you have any question to email me. You have my email on the screen. Please feel free to reach out at any point. And I'm eager for more collaborations with African countries and the African registries for more data and more collaboration. So we have like a stronger registry with a lot of countries and many patients. Thank you so much.